There's a little like screen
All right.
little right. That one.
Is Justin teaching you how to be tech savvy?
I was telling them, I honest confession, I've never hosted my own Zoom before. So this is,
Yeah,
when they weren't here yet, I was like, oh, this is gonna be a rough one.
this is a good life skill then.
Yeah, I was just gonna hold the phone on my face for it and send it out later.
Perfect. All right, well, whenever you're ready, I think we're good. I saw Tyler's on, and I know at least one of the residents is on, so whenever you're ready. Thanks for talking today.
Yeah, absolutely. So, what we're gonna cover today is the injuries and altitude sickness at sea. When I first, I was like, oh, this is kind of 65 and sunny, but it's currently snowing, so I guess this will still apply for us. Obviously in sports medicine, what we do here, we do a lot of orthopedic things. You don't necessarily think about all the medical issues that come up. But where you're working in the country, this might be more relevant to your practice, especially Justin going back out to Colorado. This might be something you see often if you're covering, ski events or anything like that. So that said, we'll get started. So, basic objectives, we want to understand, the changes in our bodies when we're exposed to the cold, same things that occur more at altitude. Talk about different types of injuries that occur with cold and altitude, and then talk about management, basic management of these injuries, and go from there. So before we get into the actual pathology, just kind of refresh, and this is some questions sometimes you see something like the CAQ about the different types of heat transfer. So conduction is probably the most obvious that we think about. We touch a cold surface, it makes your hand cold. You touch a stove, it hurts, cool it away. That's conduction. Convection is basically current fluid motion. So either liquid or gas across the surface to transfer heat. Evaporation, heat transfer, convert a liquid into gas. So sweating is the most obvious example there. And radiation, either direct sunlight or even standing next to someone, you can kind of feel their ambient radiating off. So when we're exposed to cold, it's kind of a whole body process. Obviously our skin is the first thing that picks up on this. And once it signals the thermal receptors that it's cold outside, it signals to your hypothalamus, hey, it's cold, let's make some changes to help us out. The biggest one is your body's going to shut its blood away from the periphery and back to the core to keep vital organs in homeostasis. So that, while it's a good adaptation because obviously the heart, lungs more critical, that also cold injury or your extremities. Now to counteract that, if anything, the goal is for heat reduction, heat loss. So as far as sports medicine, exercise reduces heat. So we're out running around, that increases your body temperature. Think about shivering, kind of the same. Body's trying to maintain that heat.
Door so that we can go.
So when exposed to the cold,
Close out.
when you're exposed to the cold, you want to increase your body's going to increase its metabolic rate about 2 to 5 times. Again, that's really just to maintain the heat production to offset the heat loss. With the peripheral vasoconstriction, more blood's going to get shunted to the central system, like we talked about. So this is going to increase your central blood volume to maintain your cardiac output. Now, one of the side effects that occurs with this is you eventually can develop a cold diuresis, which can lead to dehydration. So if you imagine you're bringing all this cold in the periphery, put into your central system, your body's going to perceive that as fluid overload, and you're in a diuresis for that reason. And ultimately, this has caused you to develop dehydration, especially when you're in a cold environment. We don't have that same kind of thirst mechanism. If we're outside exercising when it's 85 and humid, you go out for a run right now, you don't have that same thirst desire. So it's really important to talk with athletes, making sure that even if they're going to be exercising in the cold, to stay hydrated, even if they don't necessarily have a thirst mechanism for it. So some risk factors, obviously wet clothes, a big one. Tall, thin statured males kind of run hand in hand with low reduced subcutaneous body fat for insulation. Poor fitness, again, to maintain the offset heat loss, we have to produce heat, and if we don't have good cardiac fitness, our body has less ability to do so. Intoxication, as much as you like the idea of sitting by a fire and maybe having a alcohol beverage, this does cause further vasoconstriction, so it's actually going to further reduce the blood flow to the extremities. Lack of appropriate clothing. We'll talk more about some appropriate clothing in the next few slides. Afro-Caribbean ethnicity. So obviously folks that aren't from a cool weather environment don't have the same ability to tolerate it. And any comorbidities, particularly anything that affects your blood flow. So diabetes, cardiac disease, peripheral vascular disease, sickle cell, all these things can affect it. So ways we prevent it. Obviously, the easiest one, don't go out in the cold. If you're going to be out in the cold, make sure you're periodically coming inside and warm back up. Layer clothing, and I talked about 3 different layers to do. So your base layer, this is kind of more like synthetic blend. So, Under Armour, Nike, so it's like cold weather gear. Basically just helps kind of wick off the moisture off the skin to keep you dry. The middle layer is really what's going to there for heat. This is your fleece, your kind of big puffy down jackets. They also want to have a good drying component to them, but it's more or less for insulation. And then the outer layer is going to be what you want to use for waterproofing, windproofing, just kind of keeping that moisture off your skin. Don't look actually from penetrating the outside of the skin. Again, we talked about a few slides back, abstaining from alcohol and nicotine, as those can cause further vasoconstriction. If you do get wet, changing out the wet clothes right away, and then limit your exertion, making sure you're taking adequate breaks. So again, it's not necessarily to apply to sports, but kind of same thing. You hear every year that like the numbers spike in the winter as far as like heart attacks, people outside shoveling snow. And it's because at a certain point, your bodies can't kind of compensate. So if you already have an adverse or increased risk of cardiac disease, this can further be compounded by this. So now we'll move on to the actual types of cold injuries. So 2 different types of cold injuries. The ones we think about, probably more commonly are the freezing cold types. There's also non-freezing cold injuries, which we'll talk about in later slides. But for the freezing cold injuries, it's either going to be frost nip or frostbite. They're all kind of the same process, just on different ends of the spectrum. Frost nip is more of the mild form, resolves quickly kind of once you go inside and warm back up. Frostbite is when you actually develop some tissue injury. So the human tissue, as you can see, it freezes at around 31 degrees Fahrenheit. So, if you're exposed for freezing cold temperatures for a period of time, you eventually lose that heat. This tissue start to pull, and then ultimately it will freeze. And you develop ice crystals form within the capillary walls. Now, what happens as you rewarm, those capillaries expand and then break open, which can cause tissue damage. There's 4 different grades of cold injury, frostbite. So grade 1 is you will develop some edema, pallor, and erythema, but there's no blisters. So it's very mild form. I know here on the graphic it shows that's considered no frostbite, and level 2 is like frost nip. So that's kind of level 2, level 1 are both kind of that frost nip region. Level 2, you're going to develop more edema and erythema, potentially clear fluid blisters. This is the damage is localized to the epidermis. If you are going to have any cyanosis, it's going to be limited to the distal phalanx. Again, that's where as we peripherally vasoconstrict, it goes from out to in. And grade 3, you actually start developing hemorrhagic blisters as you get more damaged into the subcutaneous tissue. And then the cyanosis will move into the more proximal phalanx. And then lastly, level 4, you develop gangrene, so full thickness tissue loss. Some of that cyanosis will now move more into like the, in your hands and the carpus, and your foot and the tarsus. And this is something, potentially tissue death. You talk about amputations to treat it. There's some more illustrations with, grade 1 looks to be pretty normal, a little bit of erythema at the fingertips. In grade 2, you have some distal phalanx cyanosis. Grade 3, you start developing some of the hemorrhagic blisters. And then grade 4, you can also see that gangrenous looking foot. Just some examples. So kind of on, on the left, it's probably more like a grade 1, grade 2. On the right, grade 3, grade 4. So how do we manage this? So kind of the common theme, get out of the cold. The sooner you can do it, the better. Provide warm fluids, whether it's by oral intake or warmed IV fluids. If they are wet, you want to get them into clean, dry, warm clothes. You never want to rewarm in the field. So this is kind of maybe counterintuitive. If you find someone that has frostbite, you might want to think, hey, let's warm up as soon as we can. But unless you can keep them warm, this actually can cause them more damage because essentially you get a refreeze. So you really want to, if they're have frostbite, wait until you get them inside or someplace you can keep them there before you start the rewarming process. You never want to rub anything that can cause further tissue damage. So if anything, have them place their hands in their groin or their axilla where that central blood is flowing to help out. If you're able to, and there's a warming bath available, you can submerge them in there. Pain control, especially as they do start rewarming and they have more circulation back at the periphery, they'll develop some significant paresthesias. So even opioids can help with this. Antibiotics aren't necessary unless there's open wounds associated with it. And then some of the more adjuncts that it's probably a little above our level at this point would be consulting trauma surgery or orthopedics, is TPA, heparin, basically to restore the blood flow, and then possibly amputation. And then last point about compartment syndrome, in a way, you can think of like frostbite, the higher grades of frostbite almost as like a crush injury. So you don't have blood flow for a period of time, and all of a sudden you're letting all that blood recirculate and putting increased pressure in that area. So something you just want to monitor for developing afterward. The second type of cold injury is the non-freezing cold injury. And you don't necessarily have to be in freezing cold temperatures to develop this. And typically that's what you're not in. You're in these kind of more moderate, mild temperatures, but just for a prolonged period of time. These typically develop over 24 to 48 hours. And it's really thought to be, instead of the actual cold causing the vasoconstriction, it's just this kind of more mild temperature causing inflammatory response to the blood vessels and irritation to the local tissue. So the two different types are the chilblains and trench foot. With chilblains, there's 4 P's that they talk about. So it's erythematous papules, pain, paresthesias, and pruritus. And with trench foot, it's kind of this more mottled looking skin. Patient might feel like walking on hard wooden blocks. That came out of warfare, World War I, when they're digging the trenches, just kind of their feet submerged in damp water for prolonged periods. And so as we can see on the next slide, pretty classic looking trench foot right there. And then the 4 P's kind of this, erythematous papules that you can see on the right foot for perineum. So again, move the shelter, want to warm and get them back in warm air. Because typically this is more folks kind of more of a damp injury. So just let them, drying out. Pain control, some of the literature suggests amitriptyline to help with neuropathic pain, elevating the limbs, and then avoiding any pressure onto the extremities. Snow blind is not technically a cold injury, but something just kind of group it all in together. It's really thought when you're out in a snowy field that UV light essentially uses the ground as a mirror that reflects back into your eyes. Causing burning of the conjunctiva and cornea. Symptoms are very similar to a corneal abrasion, so kind of this gritty feeling, like sand in the eye, a lot of tearing, pain, and redness. And because of that reason, you essentially want to manage it like a corneal abrasion, topical and oral NSAIDs, oral antibiotics, and eye lubricants. And typically in 3 to 5 days, you get resolution of the symptoms. But that's why it's really important if you're gonna be outside when it's snowing, also consider wearing sunglasses or ski goggles. So now moving on to more hypothermia. So this occurs when your core temperature drops below 95 degrees Fahrenheit. And again, the air temperature doesn't necessarily have to be like a freezing temperature. If you're stuck outside overnight when it's 50 degrees, as we talked about previously, with heat loss, your body is going to give off the warm heat to a colder environment. And so eventually it kind of reaches equilibrium and it drops below that 95 degrees Fahrenheit. It's a spectrum of clinical features. So some are very mild, others all the way up to death. So sometimes it can be difficult to determine the severity. There are some grading scales that exist from mild, moderate, and severe. Mild, the temperature ranges are 90 to 95, moderate 82 to 90, and then severe is less than 82. The biggest thing is, from a clinical standpoint, is how they're compensating. So as we had talked about previously with shivering, that's one of your body's mechanisms to make heat. So when you have mild hypothermia, your body's still functioning normally, normal mentation, you're shivering to compensate the increase in heat production. But as you get more severe forms, you have less ability to do that. So when you start to move in the moderate range, you reduce shivering, start developing some altered mentation, drowsiness, decreased coordination. As it further progresses, now you lose the ability to shiver, start developing bradycardias, cardiac arrhythmias, loss of consciousness, and then ultimately death. So again, for management, as always, get them out of shelter as soon as possible. Warm IV fluids, get them out of their wet clothes. If they have the beds available, have heating pads, get them on the patient. You never want to move their extremities. This might not seem obvious why, but again, the way our body adapts, we shunt all our blood from the periphery to our central system to keep the core warm. So if you think about it, the blood all in the periphery is going to be your coldest blood. So if you start moving the extremities around, you're just putting more cold fluid back to the core and dropping the core body temperature further. So you kind of want to warm them up from the outside in, is the way to think of it. Cardiac monitoring is really important. Again, you can never pronounce someone, they'll say, you have to be warm and dead. If you, with, the ACLS protocols we have with the active cooling, cooling actually saves body tissue. So you can be out and, hypothermic for a long time and still be viable. Now, the caveat to that, as far as like withholding resuscitation, if there is a co-commit and lethal injury, so, you find someone down on the ground and they got impelled by, a tree, obviously that killed them. We don't have to worry about, further resuscitation. If they have a stiff chest, so if you're unable to do chest compressions, another reason to withhold care. Any type of airway instruction, so that hypoxia is more of a concern there. And if they're buried in the snow for more than 35 minutes, again, the hypoxia, not necessarily cold, would likely have killed them. So that's all the cold injuries we'll talk about. We'll move on now to the physiological, the altitude injuries, unless anyone has any questions, and again, we can do this at the end too. Okay, so as you increase in altitude, the concentration of oxygen drops. So the first thing your body's going to recognize this, it's going to increase your minute ventilation to compensate for this. Similar to cold exposure, and most times altitude and cold go hand in hand. Your body's going to increase its sympathetic tone, which is going to vasoconstrict, kind of shunt your blood more to the core to make sure your vital organs are maintaining their oxygenation. And this is all probably the immediate effect. Now, long term, after a period of a few days or weeks, your body actually will start developing erythropoietin to be stimulated to increase your red blood cell concentration to compensate for this. So ways to prevent altitude sickness: adequately hydrate, steady exertion, gradual ascent, a big one. So they talk about for every 1,000 meters you climb over 3,000 meters, take a day off. So if you start at day one at 3,000 meters, you go for 4,000 meters. That next day you take a break, let your body readapt, and then go up another 1,000 meters. There's other different types of prevention strategies where they'll have you actually, say you go up, climb 1,500 meters in a day. Well, then you scale back at nighttime to sleep another 500 meters. So you can go from maybe 3,000 to 4,500, come back down 500 meters to sleep. Next day, go from 4,000 to 5,500, then drop down to 5,000 meters of sleep. Avoiding alcohol and any sedatives. This is going to impact your respiratory abilities. And then keeping prophylaxis, we'll talk about in the next couple of slides, ways to help with this. So acute altitude sickness is the most basic thing, most common that you'll see. It's really a viral-like illness. So cough, muscle aches, runny nose. It's self-limited. So basically, once the body adapts to the altitude or you descend, It resolves, the symptom typically onset within 12 to 24 hours of increase in the elevation. Now, some ways to prevent this from prophylaxis standpoint, acetazolamide or dexamethasone. As far as the acetazolamide goes, it works by causing your body to diurese bicarbonate, which stimulates a metabolic acidosis. And so your body compensates by increasing your respiratory drive. The dexamethasone is more or less just for anti-inflammatory effect. There's not really a great why that helps, but steroids, it helps with a lot of variety of things, as we know. Treatment, basic one is descend. If you have inability to descend, dexamethasone 4 milligrams every 6 hours. HACE, or high altitude cerebral edema, is essentially, it's a continuation of acute mountain sickness. This will be fatal if untreated. It's thought to be caused by when you have that hypoxia, it's going to increase the intracranial pressure from having vasodilation, and then eventually, if not treated, it can lead to cerebral herniation. You're encephalopathic, so some of the symptoms are ataxia, weakness, altered mentation, and a reduced loss of consciousness. The prophylaxis is the same as we had talked about with acute mountain sickness. I did forget to mention, as far as when to start, you typically start 24 hours before ascending, and you continue the medication for 3 to 5 days once you reach your highest ascent. As far as treatment, immediate descent is key. If you're unable to, there's actually these portable hyperbaric chambers called Gamow bags that you can see there. The patient can go in until they're stabilized and then can descend. And also dexamethasone 8 milligram loading dose followed by 4 milligrams every 6 hours. Next is it's a PACE, it's HAPE, so high altitude pulmonary edema. And this is thought because when you have all the increased blood flow to the core, it increases your pulmonary pressure, which ultimately damages the capillary beds, causing fluid to go into the alveolar space. So essentially you're drowning in your own blood. This is the most common cause of altitude death. Some of the initial symptoms will just kind of almost be like a pneumonia. So coughing, crackles, kind of this blood tinged sputum, and shortness of breath. Prophylaxis, you want to start 24 hours before the climb and continue for 5 days once you reach your top altitude. All these strategies, the nifedipine, tadalafil, and salmeterol, are all thought to work by relaxing the smooth muscle. So they reduce the pulmonary pressure. Nifedipine is the preferred agent. However, it does have the side effects of hypotension. So if they're unable to tolerate it, tadalafil is the next in line. That does tend to be a little more costly. For treatment, again, it's descend, supplemental O2. You'll see a lot of climbers that, when they try to climb Everest, they'll have these little portable O2 tanks with them for this reason. And then nifedipine is also the treatment. So I can send this PowerPoint out later, but I took this from Up to Date. So it's nice reference of all the medications and dosing. So using a quick resource, you can use this. All right, so back to kind of some sports themed things. Training altitude, you hear these, athletes pay a lot of money to, go to different places to stay and train, or, they have all these indoor equipment where it kind of restricts your ability to breathe, essentially to stimulate hypoxia. And it all kind of stemmed from the study that was done in 1997 that looked at different training environments to see how it impacted your cardiac performance. So a lot of known, these are kind of a picture of Kenyan runners that, train and they run at a high altitude for training, and they come run these marathons in like New York City, and, they're running in, sub 3 hours. And so that's where a lot of this kind of interest started at. So in this 1997 study, what they did is they had a group of endurance athletes basically all get a baseline running at sea level. Then they split the groups up into 3. One group trained high and lived high. One group lived high and trained low, and then one group lived low and trained low. Low being sea level. And then the high living was at 2,500 meters. So out of all these groups, the only group that showed any statistically benefit with performance was a group that lived high but trained low. Now, subsequent studies haven't really looked at confirming this. They've kind of just, they haven't had good control models. But what other studies have shown is that if anything, the training high and living high is a bad idea. And that's because your body doesn't ever get a chance to kind of recover. So if anything, if a patient's asking about it, the living high and training low is probably does show some benefit. There's just not a lot of data to support its use overall. So with that said, some key points to wrap up. So your body does adapt going with cold or altitude changes very similarly because they kind of run hand in hand. A lot of that's basically getting blood flow back to the core and disregarding the periphery to kind of keep your vital organs for stable as long as possible. Treatment for cold injuries, get them out of the cold, get them warm. Treatment for the altitude injuries, get them to lower altitude and let them get back to higher concentrations of oxygen. So that's the presentation with a few CAQ questions at the end, but do we have any questions as far as the presentation goes? Any of the topics covered?
I have one.
Yeah.
With the studies of like the live high, train all that stuff, like, for like the, live high, train low, how often, like, were they going low and like, how were they doing it? Like, how did they have them doing that?
Yeah, and so they basically every day they have a very like strict regimen of what they were training. It's got a standardized running plan. And so it was just that every day that they go down to their lower altitude, back to sea level, do where their standardized training plan was, and they would go back up to the sleep at night when they're that's
It just, I mean, obviously it's one of those things like the practicality of that is not super easy.
I mean, again, a lot of these like high, endurance out. So that's what they do. Go to like they're going to their camps, and that's what it is. I mean, you think about like a lot of these training centers are out like in the West, or called the big Olympic training centers out in Colorado, and I think that's kind of some of that one like thought process here in this higher altitude elevation to help with it. People, blood doping, they take EPO, you basically that same effect. You're trying to get your body to stimulate its red blood cell mass. So that's one of the thoughts of it. Now, the EPO production, like once you come back down to elevation, like a normal like sea level, the EPO kind of normalizes within about 2 weeks. That's how when they test these athletes, like at Olympic Games, like they pop positive after that time. It's like something that seems a little kind of fishy.
Are there like certain patients that you're going to be treating prophylactically for cerebral edema or pulmonary edema, like high risk populations are like, yeah, this is the person that, or is it varying depending on the altitude that they're going to?
Yeah, I didn't come across any like who. I think it's probably anyone that plans probably do a prolonged descent. Obviously, if you're going out for a little bit a day, going right back down, it's not as important. But if you're hey, I'm gonna do a big climb and be up in altitude for several days to weeks, that's probably the population you're going for. But yeah, they didn't cover any top of like specific like comorbidities. But obviously, if someone, it does talk about if you had one of those injuries before, you're obviously prone to have it again. So in that population, okay. So a few questions. So in addition to descent, which of the following therapies is advised for the initial treatment of acute mountain sickness? So either Justin or Austin, since you're here, one of you can give us the answer. Yeah, correct. So increase the fluid intake. As we talked about, you're kind of had that cold diuresis, so making sure you're maintaining adequate hydration. And the acetazole, like we talked about, just kind of stimulate your respiratory drive. And then which of the following is a physiological adaptation to ascent? Yeah, correct. Yeah, because I talked about that's kind of the thought process between the HAPE is that as your body can kind of vasoconstrict, it puts more blood into your central circulation. It's going to increase the pulmonary pressure as a result of that. All right, that is all I have for today.
Great talk, Josh. It's super helpful for CAQ review. This stuff gets hit a lot on CAQs because it's so testable. So make sure you guys take time to review it.
Yep. Memorize all that, guys.
Any other questions? We're all good for the day. All right, everyone have a nice weekend. Thanks for coming. Or Huey.